viral hepatitis. We have viral hepatitis like A, B, C, D. Nowadays we have something like F, H, but they are less well studied. So we'll speak about these 5: A, B, C, D, E. Hepatitis A and E are fecal oral infections, first of all. B and C may be transmitted via the blood, via sexual contact, and via the vertical route from mother to child in pregnancy through the placenta. All of them, almost all of them, are RNA viruses, and all of them have tropism towards liver hepatoviruses, yes, hepatic viruses. And the only exception is hepatitis B, which is DNA virus. Though all of them affect the liver, all of them belong to various taxonomical families, according to taxonomy. What about hepatitis D? It appears as co or superinfection on the background of hepatitis B. So hepatitis D virus, which is called Delta virus, is incomplete virus and can develop hepatitis only on the presence of hepatitis B. A and E are acute infections. We don't have chronization usually after them. Not usually, we don't have. They are usually self-limited conditions. Very rarely, sometimes we may need vaccinations, but after them we have lifelong immunity. About B and C and D. They may be acute, they may be chronic. According to the definition, they are considered to be acute when duration is less than 6 months and more than 6 months is for the chronic. Complications of chronic hepatitis usually are hepatocellular carcinoma. So acute hepatitis, chronic hepatitis, it's also complication if acute is becoming chronic. Then we may have hepatocellular carcinoma and of course liver cirrhosis and need for liver transplantation. Taking into account these high numbers of nowadays viral hepatitis, let me tell you that in which groups they are possible. People who are getting multiple hemotransfusions, IV drug abusers, because the same syringe without being sterile may be used by some people. It is typical for jails, prisons, so close communities. In homosexual couples, the likelihood of hepatitis B is higher. Nowadays in tattoo salons, in dental rooms, because of poor sterilization, antiseptics of this instrumentary. And so on. Now look, here they have discussed like A, C, E together and B and D together, because B and D share a lot of similarities. So what is hepatitis? Already no need to tell. Acute viral hepatitis symptoms last less than 6 months. Acute hepatic failure when we have hepatic necrosis and hepatic encephalopathy, like unconsciousness with the 8 weeks of onset of the disease. Chronic more than 6 months. Cirrhosis, already we have spoken. We will speak. Fulminant means lipolytic. When disease has very rough course, and during a very short period may result in complications up to death. So it's potentially dangerous life-threatening condition. Targets of hepatitis B viruses are hepatocytes. So we have these phases: binding with the receptors, uncoating of RNA and DNA, translation and proteolytic processing, replication, where is it for replication, assembly of the variants, and maturation release from the hepatocytes. So their life cycle appears inside the hepatocytes. They are hepatotropic viruses. It is for all A, B, C, D, E. So we have phases: replication, prodromal, icteric, and convalescent or resolution phase. Replication patients don't have symptoms. Prodromal, when they have some common symptoms, maybe fatigue, for example, but not typical, no specific symptoms. They have icteric phase, where already we have jaundice, and convalescent phase, where liver enzymes return to normal. Prodromal, anorexia, nausea, vomiting. So to tell that they are typical only for hepatitis, of course not. There are no specific symptoms. When seen by a healthcare provider, usually patients are often diagnosed as having acute gastroenteritis or viral syndrome. So we can note that it's exactly, it's called flu-like symptoms. Flu-like symptoms or syndrome, flu-like, the same. Icteric phase and severe cases may result in fulminant hepatitis, bleeding diathesis, which means contribution to bleeding. So this patient is called hemorrhagic syndrome. These patients have high likelihood of bleedings from any part. Hepatorenal syndrome, which means that we have hyperperfusion of the kidneys and overactivation of RAS, and we may increase blood pressure and so on. Hepatic encephalopathy, bilateral asphyxis, and pulmonary edema. Clinical evaluation, look. In 80% of cases, after acute hepatitis C, it becomes chronic. HCV is considered as tender or silent killer because it may appear on the level of complications already. For a long period, it may be sleeping, 15 years, 20 years. Some are asymptomatic or have mild symptoms, others may only present with late complications, cirrhosis and hepatocellular carcinoma. Categorized based on rate of inflammation, stage of fibrosis, etiology of the disease. Sometimes we need biopsy, usually for chronic hepatitis or for cirrhosis, but sometimes for chronic hepatitis may be done, not for cirrhosis. Because for cirrhosis, classically we need biopsy to confirm, but sometimes, or very often, when we see other clinical signs and symptoms and ultrasound, CT scanning is typical for this, no need for biopsy. I'll tell you one case. 2 years ago, one of my old patients who I had been treating for uncontrolled hypertension, so 3-4 years ago I had seen him. And then it turned out that we might control the blood pressure. So he was very happy and went and appeared after 1.5 years, 2 years ago. Completely with other symptoms, like no specific symptoms, was not just feeling well. We checked everything, like had some dyspnea, some enlargement of abdomen. We checked heart, everything was okay. And also he had FMF, Mediterranean fever. Male, 55, 60 years, like this. No, 60, around 60. 59 or 60, like 60, this kid. Something I felt, but to be honest, to guess that maybe hepatitis, I just referred to ultrasound then. And ultrasound doctor, who was they went by their own, they knew him, gave very detailed description, not by CT, by ultrasound exactly. So it was written that liver ultrasound gives an impression of of chronic hepatitis changes with the transfer to liver cirrhosis. So some parts were already cirrhotic, and hepatocellular carcinoma. 2 complications at the same time. But before that, he didn't know even that hepatitis C was positive. We checked. I referred to a hepatologist, and he died after 2-3 months after diagnosing. So it was first manifest. Of course, it's not during one day when it happened. Never had. Even these are sexually transmitted infections. In this case, you need to treat the couples. And wife also underwent checking for hepatitis C virus, was negative, fortunately, but might be positive. In this case, you need to treat couples, otherwise you are treating. Look, physical examination for acute hepatitis: low-grade fever, vomiting, nausea, anorexia, dehydration signs. We may have icterus because it's yellowish discoloration of skin, visible mucosa, even tympanic membranes may be yellowish. Skin may be jaundiced and we may have urticaria rashes. Liver, we may have hepatomegaly and pain in right upper quadrant or in right hypochondrial region. What is going there? It's very interesting for me. They have barricaded by the backs and are playing games. Wait a bit, we'll play games together after 2 months. in the form of tickets. Why you are telling this I don't want to? And changing the ticket. You are paradoxical people. You are the only one, not only our students, who are paying for education, don't want to study. In normal world, people are paying and studying. You don't understand what you have. So, liver age is firm in case of hepatitis. Sharp, because round check is for right ventricular heart failure. Smooth. In cirrhosis, already is becoming nodule texture also. So about slower age, we also made an impression. Imaging studies, specific studies we don't have. It is done mostly for differential diagnosis of the hepatobiliary system or liver abscesses and so on. Liver biopsy, when diagnosis is uncertain, other co-infections, patient is immunocompromised, even may not have a fever or not that much, and also for the severity of chronic hepatitis B or chronic hepatitis C. Histologically, we will see lymphocytic infiltration, bridging fibrosis. In cirrhosis, we will see false regenerative nodules, pseudonodule formation. This is histopathological slide. Lymphocytes around the apoptotic hepatocytes. Here we have vacuolation, class of hepatocyte, ballooning degeneration, clear vacuolated cytoplasm. Lymphocytic infiltration because of viral infection. Lab studies, look, we have AST, ALT. Normally their ratio is up to 1. Because approximately they are 40 international units per liter, from 30-35 for 40-45, okay? But this is called de Ritis coefficient, this ratio. In case of myocardial infarction, it is becoming more than 1. Because AST is more in cardiomyocytes than in the liver cells. Meanwhile, in hepatolysis, if we have damage to the ALT is a marker of cytolysis. So it is becoming hepatitis less than 1. Acute hepatitis, look, ALT elevated more than AST, acute hepatitis is more than 1000, chronic ACE is more than 1000, and we are checking all markers about which we have spoken. AST, ALT, coagulation markers like prothrombin time, blood urea nitrogen, serum ammonia if we have a hepatic encephalopathy, okay? Alkaline phosphatase and so on. Deep diagnostics. All GIT, all hepatobiliary system disorders. Hepatitis A, look, acute hepatitis, single-stranded, positive sense, linear RNA enterovirus, picornaviridae family, fecal oral route of transmission, contaminated water food, very often in children, in kindergartens, or people who are contacting with contaminated foods from some area. Incubation period, you see up to 7 weeks AST-ALT, up to 20 weeks may come back to normal. High risk are travelers, vaccinations we may have, passive immunoglobulins given to those exposed. Mild self-limited disease and confers lifelong immunity to hepatitis A viruses. Sorry, other allergen. No, normal, look one second. Ha, to ganesur, unem bitter. Ha, yapayım. Ha. Hepsi nasıl gösterir? Ha, merci. So, self-limited disease and confirms lifelong immunity. Chronization we don't have. Treatment is supportive to rehydrate, painkillers, and so on. AJV, immunoglobulins, IgM and IgG. IgM earlier and IgG may persist for many years, preventing from second time, third time reinfections. Lifelong immunity. These are viremia, virus in feces, elevated transaminase phase, symptoms and jaundice, and these are weeks after infection. Hepatitis C, it's RNA virus, flaviviridae. Incubation period, 7 to 8 weeks. We have quasi-species, because each time it is mutating, And that's why for hepatitis C, it is usually skipping out of the immune system. Hepatitis C may be treated, hepatitis B may be controlled. So you may not directly get rid of this virus. Hepatitis C is possible to treat. Okay? So, look, 170 million people, major cause of chronic hepatitis in US, most common Hispanic AA population, females have it. Look, parenteral transmission, IV drug users, most common indication for liver transplantation. So it's spherical, enveloped, single-stranded RNA virus. Usually clinically is mild, does not cause significant acute illness. AST/ALT may be fluctuating elevations, 20% likelihood of cirrhosis, 50% of chronic hepatitis. Incubation period up to 150 days, symptoms developing up to 12 weeks after exposure. Diagnosing HCV, immunoglobulins against HCV. We may perform antibodies against core protein, non-structural protein, PCR. PCR. We have two variants of PCR. We have quantitative and qualitative. Very often, qualitative, just as positive or negative, is enough when we treat. Also, it has and 80% of cases are asymptomatic, they don't develop jaundice. So may be revealed already on the level of complications. Treatment, either interferons or pegylated interferons. They have antiviral effect. Pegylated is a chemically they are changed, these interferons, better sustained absorption, slower rate of clearance, and a longer half-life than standard interferons. Hepatitis E, another fecal-oral route of transmission. This is Hepaviridae family, enterically transmitted, fecal-oral, typically self-limiting. Look, most outbreaks occur in developing countries. We have acute hepatitis. 8 to 9 weeks, case fatality rate is very low. How to diagnose? Antibodies, IgG, IgM, AST/ALT, elevated cell death before the onset of symptoms, and after 2 months they are becoming coming back to normal. Treatment is supportive. Here is the case. B, it's already more serious. B, look, DNA virus, Hepatitis family. 2 billion people are affected. Look, 400 million people are carriers. Nowadays, these phenotypes were not, the genotypes, I'm sorry, were not paying too much attention. Because there was a period when treatment depended upon the genotype, from A to H genotypes. We have, you may check. But it's extra money. I mean, look, 8 genotypes labeled from A to H. 8 letters, first 8 letters of the alphabet. Well, mostly it is giving hepatocellular carcinoma. C was giving mostly cirrhosis. Not possible. Up to 10% of liver transplants are attributed to HBV. Who are at the risk? IV drug users, multiple blood transfusions, sexual promiscuity, people in contact with HBV carriers. This may be doctors, this may be social workers, nurses, especially surgeons who are contacting with the blood. Tattoo salons, I told, that's why a lot of people are taking their own instruments to this manicure, pedicure salons, not only tattoo salon, like these beauty salons are good background to give this infection. Travels to endemic areas, resident and employees of residential care facilities and healthcare workers. Transmission, parenteral, sexually, vertical or perinatal route. IV drug users, needle sticks, hemodialysis patients, because through the filter it may pass. Serology, we have S antigen, E antigen, C antigen, core, envelope, and superficial or Australian antigen, because at first it was found in Australian aborigines. HBS is detectable, is the earliest detectable antigen after 2 weeks after infection. E, after S appears very soon, indicates viral replication rate effectivity. C is the only serological marker of window period when others are negative. Also, look, we have hepatitis B as antibodies. B, but antibodies, not antigen. If it is positive, it is showing us that patient either had this condition before or is vaccinated. Usually we have 3 doses for hepatitis B vaccination. Usually healthcare workers are at risk, and in some countries it's mandatory to have vaccination against hepatitis B. So, presents after vaccination clearance of hepatitis B as antigen indicates immunity to HBV. Already have. So this interpretation of the test you may look next time for us today to manage to cover. Look, acute infection S antigen, E antigen, immunoglobulins, anti-HBe, anti-HBs, and anti-HBc total, which may be in recovery period also. Clinical presentation, look, acute, less than 6 months. We have again non-specific symptoms. Fulminant hepatitis may result in liver failure. Chronic hepatitis, greater than 6 months. These are immune tolerance. We may have high viral replication, normal liver enzymes, and immune-active variants. High level of hepatitis B DNA, hepatitis B E antigen, active replication. Carrier state with low replication. Seroconversion from hepatitis B antigens to hepatitis B envelope antibodies. Seroconversion is serum. Low HbA levels, normal liver enzymes, and reduced liver inflammation, and low risk for developing a hepatocellular carcinoma. So this is a called carrier state with low replication. So you may have immune tolerant variant, immune active with carrier state. Clinical presentation. Look, hepatitis B virus DNA is high in chronic HBe antigen negative, and is seen in late phase of hepatitis B virus. Liver enzymes are resolution, viral clearance of hepatitis B virus DNA. Serology. Sometimes we need even liver biopsy for the grade and for the stage. I'll show you now. Liver biochemistry, like AST, ALT, alkaline phosphatase, total bilirubin. Histologically, we have immunoperoxidase staining for hepatitis. HBV DNA, most accurate marker, and is detected by PCR. So PCR in both hepatitis C and V is done. Progression. Look, incubation period maybe up to 180 days. Acute may resolve 90 by themselves. 1% may develop fulminant like lightning failure. Chronic HBV infection. We may have chronic state, 90% in children less than 5 years old progress to chronic state. Risk of liver cirrhosis. It is accumulating risk. After 5 years, risk from 8% is becoming 20% for liver cirrhosis. This percentage you don't need to memorize. I want you to understand again. 5 to 10% of patients, of this patient progress to hepatocellular carcinoma without preceding cirrhosis, and less than 5 achieve a chronic carrier state. As far as treatment is not in your program, I'll just superficially tell we have interferon therapy. We may have nucleoside analogs and nucleotide analogs. Tenofovir, aduloflovir, so antiviral medications. We don't need these. Prophylaxis, we have hepatitis B vaccines, we have hepatitis B virus pregnant mothers. And here are written about the dosages and so on. Again, when should be done, how should be done, no need for you. Because you pass gastroenterology in 5th year. This is for propedeutics, how to diagnose, which markers, pay attention to this. Hepatitis D, look. Also, please pay attention to other types of hepatitis. Alcohol-induced steatohepatitis at first, and then fatty liver disease. Alcohol-induced, drug-induced, autoimmune, with its LKM variant, soluble antigen variant. In Davidson, everything is written. Ischemic hepatitis, and of course in Harrison also is written more details, but at least Davidson take into account. Hepatitis D, look, it's only as co-infection with acute or superinfection and chronic HBV carrier, because it needs hepatitis B S antigen superficial for its replication transmission. May progress to chronic disease, incubation period you see. Hepatitis serologically we have anti-HBV antibodies, which is indicating superinfection. Antibodies not always present in acute infection requires repeat testing. Risk factors same for those with hepatitis B, prevention, avoidance of hepatitis infection B or vaccine, hepatitis 2 diagnosing antigen or antibodies towards HDV. Clinically, co-infection is self-limited because it's acute. Superinfection, acute HBV carriers present with a severe acute hepatitis infection with increased risk for HDV infection. We don't have cirrhosis usually, and treatment is interferon alpha. A few issues about this. We have reflex testing for hepatitis B and C. Right now, reflex testing. Reflex testing is that when we are giving the blood to the analyzer, and it finds for hepatitis B S antigen, for hepatitis C antibodies, directly from the same sample, automatically it is performing PCR for hepatitis B and C. It's called reflex testing. Usually, for example, you are giving these antigens. If they are negative, very often it's enough. Then if there is not, you are doing PCR. This method allows at the same time, if it is positive, device senses analyzer. If it's positive, hepatitis B superficial antigen or surface antigen, automatically it is doing also PCR to identify by polymerase chain reaction the genome of the amplification of the virus and to identify the virus more distinctly. Okay. So these were main issues today I was going to share with you. If you have any questions, please. If no, you may go.